Pelvic C clamp, emergency stabilization instrument for unstable fractures of the pelvic ring. The Pelvic C clamp is used for the emergency stabilization of unstable C-type fractures of the pelvic ring with hemodynamic instability. Unstable pelvic ring fractures can be associated with massive hemorrhaging, which can lead to terminal shock. The Pelvic C clamp allows rapid reduction and fracture stabilization, leading to control of the shock reaction. To control shock in unstable pelvic fractures, it is critically important to achieve hemostasis by exerting pressure on the fracture surfaces. Due to the severity of the trauma and the poor prognosis following protracted shock, the Pelvic C clamp should be applied as early as possible. It can be mounted during emergency treatment together with shock treatment and emergency diagnosis. The application of the Pelvic C clamp takes approximately 10 minutes. The following instruments are used. 2 cannulated nails for the Pelvic C clamp, which are either 190 or 210 millimeters in length. The guide handle for 2.5 millimeter K-wires. The 2.5 millimeter diameter K-wire with a length of 280 millimeters. The 11 millimeter socket wrench with hammer. The 11 millimeter ratchet wrench. And the Pelvic C clamp. The Pelvic C clamp is constructed of a rail and 2 arms. Each arm has a locking mechanism. This allows for a linear movement of the arms. The Pelvic C clamp should always be used in combination with the designated cannulated nails. Preparation of the Pelvic C clamp. The upper bars are extended by pressing the buttons on the upper rails and pulling on the side arms at the same time. To prepare the Pelvic C clamp for use, the lower side arms are opened by pressing the buttons on the arms. Make sure the threaded tubes are turned in the position shown here. The cannulated nails are placed into the threaded tubes while twisting slightly. The little teeth on the tip of the nail allow a better grip in the bone. The buttons on the top of the Pelvic C clamp may be locked. However, the buttons must be unlocked when the Pelvic C clamp is applied in order to obtain the necessary compression. The indications for the use of the Pelvic C clamp are emergency stabilization of complete sacroiliac disruptions and fractures of the sacrum in type C pelvic injuries with associated circulatory instability. The contraindications are fracture lines within the ilium, transiliac instabilities, transiliac fracture dislocation as it bears the risk of pin perforation through the fracture line, and C-type pelvic fractures which are hemodynamically stable. In this presentation, the presacral venous plexus and the vesical venous plexus are represented by blue tubes leading to a water-filled bucket. When the C-clamp is applied correctly, the air supply through the two balloons is interrupted, as shown here. The anterior superior iliac spine is palpated and marked. The tip of the greater trochanter is marked. The incision point is marked at the intersection of the line which extends the line of the femoral axis over the tip of the greater trochanter and a vertical line from the anterior superior iliac spine in the dorsal direction. The entry point should be marked on both sides of the patient. An incision is made at the point marked previously. It should be noted that the surface reference point of the outer side of the ilium changes at the level of the sacroiliac joint. In emergency situations, the resulting fossa can be used as a point of reference. To securely anchor the pelvic C clamp, it must be placed at the level of the sacroiliac joints. Palpation with a blunt instrument, such as the guide handle for K-wires, allows for easy identification of this site, even in cases with severe soft tissue swelling. An optimal nail placement is important to prevent injuries to the nerves, blood vessels, and organs. After the insertion point has been identified, a K-wire can be placed through the guide handle on the uninjured side. The K-wire is fixed onto the bone by gently hammering it in. This K-wire ensures the exact placement of the cannulated nail and prevents the nail from slipping. After the insertion of the K-wire on the uninjured side, the clamp is applied with the cannulated nails in place. The first nail is slid over the K-wire and a secure grip in the bone is verified. The second nail is placed on the injured side. On the injured side, a K-wire is not used. After incision, the nail is slid towards the bone at the described entry site. Before definitive compression, reduction of the displaced hemipelvis is achieved by traction on the leg, internal rotation, and further compression of the clamp. If possible, the reduction and positioning are checked with a C-arm. After both nails are correctly seated, the upper side arms are compressed manually. The correct application of the C-clamp with good compression is indicated by the interrupted airflow through the blue tubes, as shown here. The locking mechanism secures the upper buttons and prevents the unintentional loss of compression during movement of the pelvic C clamp. Final fixation is ensured by tightening the threaded tubes with the ratchet wrench. The K-wire may now be cut off with the wire cutter or may be completely removed. After complete application of the pelvic C clamp, the fixation is verified with the C-arm or an X-ray in the AP view. Once mounted, the pelvic C clamp can be swung both caudally and cranially and should be positioned as shown here.